So the theme of this session is living donation and other forms of transplant. And it's my privilege to start this session. Talk a little bit about living donation. And the question is, why would we need living donation in Sweden when we have so many deceased donors? And as you heard from Sandra, we're chucking a lot of them in the bin. So what we've done so far really is looking at how to expand the number of organs available. And we've expanded criteria for deceased donors in DBD. Then we went down the route of DCD, as you've heard from the numerous sessions today. We've changed the legislation. But that doesn't appear to be enough. We still have a gap. And I think that the avenue that we really need to explore is living donation. Of course, we need to reconcile this with the traditional oath of primum non nocere, but I think there have been numerous changes in the societal interpretation of this, and living donation now it's accepted. Why? Simply because it does provide an elective environment. It's not a 3 o'clock in the morning. It's an advantage for the recipient because you can actually, in the kidney situation, avoid dialysis, which means less costs and better outcome. And of course, they have economical advantages. Just to give you an idea how important preemptive transplantation is, if you look at the green line over there, that's living donation without dialysis. So that's the first treatment a patient with a renal failure sees. And you can see immediately that the outcome is significantly better, and it doesn't even compare with dialysis alone. Just to give a quantification, it almost doubles the life expectancy of a patient. So I think there is no brainer why we should consider living donation. And again, if you look at longer term, which is important for the patient, is not the immediate success, it's actually the long-term outcome. This is significantly better, particularly if it's done preemptively. So to do this, we need people, we need the public to donate. And it's important because when you ask them what's relevant to them, if they were to donate, this is some interesting data. Look at what they say. They're expecting at least 50% survival for the patients. And for the donor, rather shockingly, they say if we get a 79% survival, we'll be happy. Now, clinicians will not be happy with that. They will want 100% survival for the donors. But the other interesting thing is who they donate to. And if you look there, is 83% will give to the family, 56% will give to a friend, but increasingly people are donating to a stranger, which is the non-directed or the altruistic donation. And this is an important bit because that's how we increase exchanges and make transplant more available. So the next question is, do we need living donation in Sweden? And this is a snapshot from the document that Mirella referenced this morning from the most recent newsletter of 2022. I want you to focus on two things, kidney and liver. And if you look there, is 4,000 patients still on dialysis and 16 patients still die on the list. There's 16 too many. And again, on the liver side, 10 patients on the list. It may not seem much, but it's still about 9 to 10% of the waiting list. 10 too much. So we need to do different things. So clearly, although we have good living disease donation, that is not sufficient. And for me, this is the argument to consider living donation. So if you look at the current status, it's 9.7 per million population. Looks good compared to other European countries, but bear this in mind. 6 years ago, we were much higher in this country. So the interest in living donation has gone down. Why? We don't know. Is it because of the risk for the donor, or is it because the wider availability of deceased donation? How does it compare? Well, here's against two of the key promoters of living donation, South Korea and Turkey, closer to home. And you'll see immediately there that there's a huge numbers of living donation, both in liver, both in kidneys, but also other livers, other organs such as liver. 12 million in Korea, it's a lot. So the overall philosophy we should embark is really educate. That's a key point, educate patients, doctor, general public, early referral for the patients, provide the evidence-based, and push and extend. And we can use this in a very smart way because it's not about one-to-one. We can actually put that into alternative programs, sharing putting patients who otherwise will not get a transplant because they don't have a compatible donor. And we need to consider how we can start sharing across the boundaries, and Scandinavia is a very good place to do that because of collaborations between the centers. So that's for kidney, but what about liver? Because that's the one that it doesn't happen in here. So again, this is across many countries. You'll see the green, dark green, the living donation per million, or the domino as well. But here's a different problem. It's a risk. It's greater than kidney transplant. So the more part of the liver you remove, going from smaller part, the left lateral, to the extended right graft, the higher the risk. And therefore, we need to find a balance. And that balance has been very clearly demonstrated in this forum, which was written a while ago, looking at the care of living donor. The risk is justified by the expectation of an acceptable outcome. And I think that is an important point to make. So, there are a number of tick boxes there, because essentially this is what happens nowadays in terms of how we consider the recipients and what are we trying to achieve. Comparable outcomes, I think actually they are better than deceased donation. The same indication, but now this is again changing because we have an increased demand, particularly from oncology. And we should offer a survival advantage, and we do, because otherwise people die on the waiting list. And for kids, this should be the norm. We should not deceased donation, we should really be living donation. So I think what we're dealing in liver, unlike the kidney, it's a double equipoise, where we've got how much donor risk is acceptable, how much, what are the acceptable recipient outcomes, to try and strike the right balance. So I'll close here because you got some very important speakers after me with a lot of different perspective of different donation. Living donation should really be standard in any country because it makes a significant contribution to transplant activity. It goes without saying that donor safety is paramount. For the kidney, now minimally invasive, and now robotics is becoming the standard of care. But there is an unrealized potential both for kidneys and also for liver, and there is scope to expand that. And we're looking forward to working with the relevant teams and the Socialstyrelsen to try and make this happen and really bring it to the patients, because we should not have patients dying on the waiting list. Thank you. Any burning questions? No, great, thank you. Yeah, let's go for one.
Cutting it short, I think we have quite a lot to do post-transplant, not the least to the citat you put up there with having more willing donors when we can preserve the graft after a transplant. And I do think we have quite a lot more to do there.
I think the biggest thing we need to do is actually education. And education is also for professionals to promote living donation. There is a slight fear that donor may suffer. There is some evidence, particularly from Norway, that long-term there may be an impaired function. But reality, I think we need to trust our patients and our public, because what we think it's right, they may not see it the same way. They might prefer...
And listen with the big ears.
Very big ears. And I think that is what the shared decision is about. I think our duty as physicians is to provide the correct information that allows the donor and recipient and their family to make the correct choice
for them.
Exactly, for their situation. There is a very good example in a number of countries now. The home education is needed, because how much time we have in clinic with the patient, 5-10 minutes. I'm sorry, but living donation cannot be promoted and discussed in 10 minutes. So for this to work, we need to create an educational package that we take someone in their patient's home with all the public and the family around, and they can make that decision and have an open conversation. And we know that this approach increases their attitude and knowledge about the range of treatment, not only living donation, but allows that to happen. Okay. Then it gives me great pleasure to introduce Alexandra Karström. who's the head of cell and tissue therapy lab at the plastic surgery department in Uppsala in Sweden, who's going to talk about other options for transplant, and that is transplantation of the skin grafting. Alexandra, welcome. I look forward to hearing from you.
Thank you. It's a pleasure to be here. Thank you for inviting me. As you said, I will speak about another dimension of donation, namely donation from the patients itself. When you have a severe burn, you're treated at a burn center, and since 2010, this is a nationalized care in Sweden. So instead of performing it all over the country at all university hospitals, it's only performed in Uppsala and Linköping. Each year we have 36,000 contacts with the Swedish healthcare due to burns, but that's also from the very small burn blisters that kids go to school nurse for. And out of those 36,000, 1,300 need hospitalization, and 500 of those are very serious. Some background. There are several key elements for defining the severity of the burn. Of course, how large part of the body is damaged. And you used to say that the hand palm, including the fingers, correspond to 1% of the body surface. And also the depth of the injury, how deep in the skin is the burn, and what has caused the burn. Is it a flame, electricity, chemical, or a scald burn? Has the patient inhalation injuries due to the flames or other injuries? And was it a healthy person before the accident, or did the patient suffer any illness before? So the needs for the patient is to receive a permanent cover and also a temporary solution for its wounds. And for a permanent cover, you have two options, both donating. You have to take the base for treating burn patients is to move healthy skin from the patient to the burned wound and work like that until you have covered all the burn wounds. But if the burn is too great at the body, you have to take a small stamp of skin and culture cells instead. And while doing both of those things, you need to temporarily cover the burn wounds with something. So donation is a key element in the burn care, actually. So the treatment strategies are the patient's own skin in thin sheets, if it's available, and the lack of available skin starts already if 30% of the body is damaged. So it's quite quick that you reach a deficiency of skin. And the alternative is to culture the skin cells. And if you do that, you receive a medicinal product, an ATMP, advanced therapeutical medical product. And meanwhile, as I said, you need donated human skin from deceased. So it's the deceased donation is also a cornerstone in the burn care. But I will focus a bit more on the living donation. And the part thickness is the working horse in burn care treatment. And you have a dermatome and take thin slices of split thickness grafts that you mesh to expand them and also make them permeable. And from the graft site, the skin will heal and you can take a new thin sheet. Sometimes the surgeons harvest more split thickness grafts than needed during one operation. So then you can store the skin and use it for a later surgery within 4 weeks. And if you have a lack of autologous skin, you start with a biopsy in the size of a stamp from the patient, and you go to the clean room facility and start producing cells. And when you have reached enough amount, you can go to the operating theater and deliver the cells to the patient. And Uppsala University Hospital is the only hospital in Sweden that have a license from the Medical Product Agency for this. So here you see the cells. This therapy has been in use for 30 years, and the first method of doing it was making puzzle sheets of cells, put them in small transportation boxes, and go to the operating theater and place them onto the wounds like a puzzle. But nowadays, you make a cell suspension that you bring to the operating theater, and at the operating theater you mix the cells with the tissue glue and spray them onto the patient's wounds. So you can create a new costume of skin if needed. And the background for this is two American guys that in 1975 developed a method for culturing cells into sheets, and 81 they were used for treating 2 small kids that were badly burned. In a more regulatory perspective, this was a therapy that was developed within the research field, and then it has developed over the years and been covered by the cell and tissue law, and today it's considered a drug, and it's the drug legislation framework that is applied. So manufacturing keratinocytes for burns is producing an ATMP drug, and you have to have permission from the MPA, and we have a permission within the small regulatory frame called hospital exemption. And ATMP area is an expanding area, but this is a therapy that has been used for more than 4 decades in Sweden. So to conclude, donation is really a cornerstone in the care of severe burns. Living donors is the patient itself, and it gives the patient a permanent cover, but we also need the deceased donors because we need to temporarily cover the wounds with something. And culturing cells producing the ATMP has been in use in Uppsala since the 90s, and it's a very important thing to be able to use when there is no other possibilities for saving the patient's life. Thank you.
Fascinating, and I have to say I learned lots of things, and I've got a couple of burning questions, but one challenging one, should they really be a medicinal drug, or because they're donated? And I'm sorry to go right to the deep end. Should
Yes,
they not
you
be
go to the burning question.
Correct. Should they be a transplant rather than a medicinal project?
Yeah, I think everyone in the profession would like to see it as a transplant.
Good. So hopefully in Santander we'll have a meeting where we're going to fix that. And also, along what Sandra was saying, it's amazing what centralization can do, because I don't think the progress you've demonstrated here and would have been possible in small units. So
No, because you need the patient, the therapy, and the surgeons at the same spot.
Glad we occasionally have views. Any other questions? Thank you, Alexandra.
Thank
and now we go to the last speaker, last but not least, as we say, Nicole Silverstolpe.
Right. Yeah,
Perfect.
Right. Exactly.
CEO of the Tobiasregistret, which is the Swedish registry for blood stem cells. So that's an important thing, because we heard a lot about ATMP and stem cells here. And Nicole, tell us where we're going next with this.
Exactly.
Thank you.
So like this. Right. So I'm just started as a CEO of a Tobiasregistret that I think many of you might have heard about before. We are based in Stockholm, but we provide all Sweden and the rest of the world with blood stem cells from Swedish young people. Like this. Oh, like this. Okay, perfect. So these are the people that we want to talk to. These are young people. They are 18 to 35 years old, and they are our heroes, of course. They take time from their own to give to some person that they have never met. And for donation to be possible, we need to find a patient that has exactly the same HLA as the patient. And for most patients, they can find someone within the family that'd be like 30%, and the rest has to go abroad to find something else, an anonymous donor. Like this. I'm not sure if this is supposed to be a movie, but anyway, we have an ambassador. This is Eric. He is a rock singer, and he was saved by blood cells earlier 2 years ago. And he nowadays provides us with a movie that we send out to everyone that applies to become a donor of blood stem cells. And this is the kind of work that we have to do, because we are trying to find the really young persons to come to our register. And it seemed to be something that should be really easy nowadays, when you have TikTok, you have Facebook, you have Instagram, you have everything. But it is really hard to make young people find this, understand what to do, and actually do it.
Hej! Tack för att du har anmält dig till Tobiasregistret. Det är personer som du som gör det möjligt att rädda livet på någon vars sista utväg är nya friska stamceller. Jag är ett levande bevis på varför. År 2021 drabbades jag av akut lymfatisk leukemi. Men genom en anonym stamcellsdonator räddades mitt liv. Hela 2021 kämpade jag för mitt liv. Tack vare någon som du så lever jag idag.
Right, so this kind of movie we send out for the young people, and hopefully they will provide their friends with this movie so they get interested to see what to do next. So how do you become a donor? Well, it's really easy. You just get on the internet, you fill in a very quick form, and we'll send you a TOPS kit like this. You swab your cheek, and within a few weeks, we will have you in a system where you will be searchable for the rest of the world. We provide blood stem cells for Sweden and for the rest of the world, and it's about 50-50 that goes to Sweden, and the rest goes to other countries. So what do we do? Well, you have to answer a few questions. You have to be a healthy person. You have to be 18 to 35, and a little bit like Gabriel was talking about, you need a healthy person, but you also need someone to put it in, because they are putting at great risk to have the stem cell transplant. So the the chance of them getting healthy is so much bigger if you have a young, healthy person to start with. The younger, the better. But in Sweden, you have to be 18. So once this is done, it takes a few weeks, and then you are searchable for the rest of the world. And every day there is a lot of searches being done, at least hundreds. And as I said before, this will be done for all over the world at the same time. We think one of the reasons why people are afraid to join is that maybe they think they have to take bone marrow from the hip, that is going to be something very painful or very difficult. But as we said, you start with a swab, and then maybe you need to go and take a blood sample. About 1,000 of our givers have to go and take a blood sample, but only 200 will eventually actually donate. So it's a lot of people being collected, but not so many have to give or can give, unfortunately. And from our perspective, it's from vein to vein, supposed to be within 36 hours from when you leave the blood stem cells until they go to someone else to find the new home. This is one of our greatest challenges. You see all the red hearts, that's a register in the world. Our registry was started by a family that had a son that never found his match. So in frustration, they started the register. And when you see where these hearts are, it's mainly the well-situated countries where we have all the registers. This is a big challenge because nowadays, people find their loved ones all across the world, and you never know what kind of match this is going to be. So there are big spots here that is white, and we need them to be filled. And we also need to fill our register with a young male, and with the male that has a different culture or grown up not only in Sweden but completely mixed. So that's really a challenge for us. So in the world there's 41 million donors possible to find, but still there's still 1/3 that never gets the chance to find the donor that might be the last chance for them to survive. So this is our biggest challenge, to come out, to get all the world to be to understand that everyone needs to be in a register, and also to understand that you're only a good person to get mixed with when you are young. So this is a picture of a donor and a giver that sometimes meet. This is also one of the things that helps us very much, is when you have something in the big newspapers where you have someone looking for a donor, if they eventually find that's a donor and survives, like this couple here, they have survived. The grace makes a great history, and is also the thing that makes people want to contribute to being in a register. So what I like you to do now is, since I think most of you are actually over 18, you couldn't go home and talk to your children if you have children in this age, or grandchildren, or at your workplace, but try to talk about there's a possibility for young people to help someone in the world. And in this kind of world that we're living in now, when democracy is threatened all the time, you can actually do something for someone anywhere in the world, and that will be their last chance to have the perfect match. Thank you very much.
Fantastic initiative. Any questions? How do you fund it? Who funds the registry?
It's funded by, every time that we sell this product, it's the same price all over the world. We get 220,000 Swedish crowns for it, and that is how to have the employees at register.
So that cost covers your production
Yeah.
and processing fees
Yeah.
without making a profit?
No, exactly. So we're supposed to have a zero result. This year, since we're doing really well, we might have some money over, but usually it's a zero result.
Okay.
Yeah.
What do you think about companies that use anonymously or human-donated organs for profit and cells, and then they enhance them, and then they sell them at huge profit?
That makes it very, very complicated, because we don't want this to become a business. And especially when we ask these young people to come and do this, to give of their time to do something, we also find it a bit tricky. Can we use, if this transplant would not get used, can we use it for something else? Possibly research, but we have not even come to that. So I personally find it very difficult.
Agree. Any other questions for Nicole?
Yes. 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 It's if someone has a patient in Bolivia, they go out for the same search, and we will have a message, and then they will search for the perfect match, and they most likely find maybe 10. And then these 10 will go and give a blood sample. Then they can pick the really perfect match. So that's how it happens. So that's a really amazing thing.
Excellent. I think we've got a hard stop at 3. We've got a bit of time for a coffee before that. Thank you for staying, and thank you for the speakers for very, very entertaining and interesting presentations. I learned a lot today, so thank you.
Thank you.